from Korea, right? And he's going to talk about brow elevation and design for Asian patients, the vector control, and also longevity.
Yeah, so I must say, Dr. Lee is the National Secretary of ISAP of South Korea, right? And also, Dr. Lee is actually very well known for breast surgery.
In this topic too, right? Okay, go ahead.
Nice to meet you. Good afternoon, ladies and gentlemen. I'm Hong Lee from Seoul, Korea. It's a great honor to be invited to here to have a speech. In addition to the 2 years ago in Vancouver, thanks to Dr. Kao and Dr. Riku. Today I will make presentation about my experience of endoscopic forehead lift that will consider ethnic variation in design strategy and vector control, even in the durability. When we have aging process, definitely we have some aging sign of the upper face. That would include sagging down of the eyebrow or puffing and narrowing of the upper eyelid crease and dynamic wrinkles of forehead and profit areas. We need to solve this problem with aid of upper eyelid surgery or sub-brow excision in addition to endoscopic forehead lift. In my idea, endoscopic forehead lift is the most natural reversing process. We need to reverse aging process that's gone with gravity. But to make optimal forehead lifting for each ethnic group was not easy because there has been an ethnic difference and individual request and complications that follow. So today my topic is how to make optimal forehead lifting job, especially for Asian ethnic groups. Who live in Asia like China, Korea, Japan is quite different than who lives in America. American Asians, they have definitely different ethnic concept with the people who live in Asia. Those are idols of the American society, as like Angelina Jolie and Kim Kardashian and Zendaya. Each have different aging groups. Those are Korean celebrities, Lee Young-ae and Song Hye-kyo and Jennie in Blackpink. Those are celebrities all over the world nowadays. If you simplify those celebrities' picture, we can tell there is definite different ethnic appearance, especially on upper face area. Different ethnic group has different preference for eyebrow shaping. So without understanding those factors, we cannot satisfy each ethnic groups. As you see, right side, Caucasian society, they prefer high arch in lateral to third or diagonal in Middle East Asia. But Asian patients who live in Asia, they love parallel or very mild arch shape of the eyebrow. That means medial eyebrow should be handled very carefully. Without handling that medial eyebrow, we might say, I have angry look because we don't like high arch eyebrow in such case. So we need to handle medial eyebrow carefully, but in medial eyebrow area, there are many factors to consider. Corrugator muscle, procerus muscle, depressor ciliary muscle, etc. In addition to that, there is supraorbital nerve and supraorbital nerve. That makes big problem for us. For my journey of 25 years in endoscopic forehead lift, I have encountered several problems and challenges. I need to choose appropriate technique for according to the indications, and I need to control the lifting vectors also. And I also need to make prevention and correction of asymmetry in long-term follow-up. So many doctors in Asia, they worry about the endoscopic forehead lift because of nausea, vomiting just after the operation, and long-term follow-up paresthesia and dysphagia in the case. To choose appropriate technique according to the indications, when we have patient heavy eyebrow and brow ptotic patients, I did with the subperiosteal dissection with the release of the periosteum inferior to the eyebrow, so I can lift the eyebrow effectively. But we can, even in a very young patient, use this kind of improved result, even in 2 years follow-up. But the gentlemen who require eyebrow lift in addition to frontal wrinkles improvement, I need to add another factors with the horizontal scoring of the periosteum around the forehead linkers that I can easily spread horizontal forehead wrinkles effectively. In addition to previous subperiosteal dissection at the inferior eyebrow area, I add horizontal scoring of periosteum to improve horizontal forehead wrinkles. With this technique, I can induce definite improvement of heavy eyebrow ptosis plus improvement of his horizontal forehead wrinkles. But sometimes patients, they ask us to improve her forehead wrinkles only without elevation of her eyebrow. In that case, we can do supraperiosteal, that is subgallate dissection without least of supraorbital ligamentous adhesion. That can preserve pre-periosteal loose area tissue and periosteum. With this technique, I can make this kind of result in 2 years follow-up without definite elevation of her eyebrow. In addition to such kind of indications, we need to control the elevation vectors according to patient request. In our society, this kind of patient, they think, my friends always tell me, are you angry? So this kind of slanted eyebrow shape is a kind of angry bird looking. So we need to elevate her medial nasal side eyebrow effectively. That is our ethnic group's request. In addition to that, a very young lady who has slanted downward eyebrow, we should do selectively lateral eyebrow elevation also. With the elevation of the asymmetric eyebrow, even we can guarantee long-term follow-up. If this is 12 years follow-up, she can still maintain a very balanced eyebrow position. So even with endoscopic foot lift, we can guarantee the correction of asymmetric eyebrow effectively. But how to do this operation with the correction of asymmetry and longevity result? In my idea, especially when we deal with the patient who need correction of asymmetry, asymmetric amount should be measured when the patient is standing position exactly, and in the operation room there should be handled some kind of overcorrection. In my case, when I do subperiosteal dissection, I do 20% overcorrection. When I do subperiosteal dissection with the periosteal scoring, I do 30% overcorrection. When I do subgallate dissection, I do 40% overcorrection. In my operation experience, I can make a long-term result of asymmetric correction. But one thing to remember, we know how much flat posterior abdomen should be made before we make any dissection. So to have that, we need to make bone marking before dissection where we have started. Then we exactly guarantee how much amount of posterior advance or flat was made. With this kind of preoperative planning and intraoperative technique, we can guarantee the correction of asymmetry and prevention of some problem. Some doctors in Asia, they have worries and dissatisfaction of the long-term result. But as you see, I have many patients who has 20 years follow-up. As you see in these photos, she has 20-year follow-up, but she still have definite improved position without any recurrence of sagging down. So with this result, I can definitely say endoscopic eyebrow and forehead rejuvenation surgery can guarantee long-term follow-up without worrying of the recurrence. But still, so many doctors in Asia, they worry about endoscopic surgery because the patient complain nausea, vomiting just after surgery, and long-term follow-up of the phalangeal dysaesthesia issue. With my experience, I have found that when I did pure subperiosteal dissection until infrabrow position, the patient had a severe nausea, vomiting, and long-lasting nerve obstruction symptom. They complained. But when I add horizontal periosteal scoring, patient complaint and symptom was quite less. The patient who I did subgallate dissection only, they complained minimal amount of nausea, vomiting issue, and the long-lasting dysphagia paresthesia was quite minimal in comparison with the other patient group. With my experience with that, I need to prevent nausea, vomiting issue of just after surgery with the post-operative nausea, vomiting prevention method. So in some cases, you can use ondansetron, better medicine effect can be made halosterone with a combination of dexamethasone. But major issue may come from not from the medicine, but you should modify our operation technique. As I told you, If I do only subparietal dissection with infra-eyebrow release of periosteum, focal nerve traction at foramen or notch of supra or supratrochlear nerve area was made. In that case, severe nerve traction symptom at just root area. That made a very severe nausea vomiting to the patient. But if I made horizontal scoring along the forehead wrinkles, the patient may have quite less symptom because divided nerve traction tension over several points of forehead. So in that case, the patient complained quite less symptom of nausea, vomiting, and dysphagia. In the patient group who has subgallate dissection, the patient group did not complain nausea, vomiting, and dysphagia, paresthesia issues. In that case, with the subgallate dissection, with the preservation of the pre-periosteal loose connective tissue, make preservation of the nerve traction along the whole forehead that can minimize nerve traction symptoms. With my experience of those cases, I changed my operation technique from subperiosteal dissection with the infra-eyebrow release technique to periosteal release at suprabrow level and preservation of pre-periosteal loose connective tissue plus horizontal periosteal scoring. That means I don't need to make a focal nerve traction symptom area at nerve root, but I can deliver even distribution of nerve traction area along the forehead. With those techniques, I can minimize nausea, vomiting issue. I just have surgery, paresthesia and dysphagia, and long-term follow-up in the patient. Because in our ethnic group, we need to handle medial eyebrow also. This kind of issue is so important for my areas. So with my 25 years experience of endoscopic lip, I can modify my operation technique according to the patient indication. And I understood there might be control lifting factors and how to prevent and control HV can be made. And I can have confidence we can make a long-term maintenance result with even in the endoscope without any coronal incision. We have worried about nausea, vomiting issue, just have surgery and paresthesia when this is a long follow-up. With improvement of operation technique, we can minimize the discomfort of the patient with endoscopic surgery. That was my experience with 25 years. Thank you so much.
Thank you so much. That was great.